And again, bienvenue, bienvenidos, and Cade Mil Falcha, which is Gaelic for 100,000 welcomes from the little Irish girl at the front here. So the Canadian Health Coalition put a great conference together for the next day and a half for all of you to participate, enjoy, and get to know more, as I said. The Canadian Health Coalition is made up of unions, community groups, churches, students. We even have a lawyer on the board, which comes in handy, or it could come in handy. And so I would like to take one moment of your time to thank the board members who are attending here today, and just please stand when your name is called. We'll start with Barb Byers from the Canadian Labour Congress. Barb and her fan club. Julie White from the Congress of Union Retirees of Canada. Keith Newman from the Congress of Union Retirees of Canada. And anytime you see a U, you have to say union, right? Michelle Brill-Edwards for the Alliance for Public Accountability. Michelle, not here yet, okay. Heather Finn from the Public Service Alliance of Canada. Shelley Gordon, Canadian Union of, there she is, Public Employees. Pat Van Horn, United Steelworkers. Sandra Azokar from the Friends of Medicare from Alberta. Rita Morbia, Inter Pares representative. Marie Buchan, United Food and Commercial Workers. Anil Naidu, Nupchi. He just crossed over from the CFNU, so it'll take me a while to get my head wrapped around where he's working now. The Unifor rep, Andy Savella, could not be here today with us, but we do have somebody who is well known to a lot of people in this room, and it's Mike McBain. Could you stand, please, Mike? Mike McBain, the guardian of Medicare, hey? Welcome, Mike. Thanks to all of our sponsors and to the guardians of the public health care, the Public Service Alliance of Canada, Canadian Union of Public Employees, the Canadian Labour Congress, and the Canadian Federation of Nurses Unions. So in addition to being the chair of the Canadian Health Coalition, I'm also the Secretary-Treasurer of the Canadian Federation of Nurses Unions. I'm a registered nurse, and I continue to work at the bedside in my unit in the recovery room at the University of Alberta Hospital, and which is actually the best place to work in Alberta, just so you know. And I'm always grateful to my friends at work, my coworkers, and my colleagues for allowing me to be here with you in instances like this. They are the ones that are doing the heavy lifting when I'm away, so I have to thank them every time I'm away as well. So thanks to them. And now we'll have Adrienne Silnicki, who is our national coordinator at the Canadian Health Coalition, and she will take the podium. Thank you, Adrienne.
Good afternoon, everyone. A couple of housekeeping items. So there are washrooms just to the outside this door. Make a right again, go through the lobby. They'll be on your right-hand side. So if in doubt, just keep turning right and you'll eventually find them. We do have translation devices. This is a bilingual conference, so some of the presentations will be done in French, some in English. If you do not have your device, please just go to the back of the room, where they're holding them up right there for you. So you can actually just put up your hand if you need one, and just leave it on your table when you're done today, and they'll be collected. For cameras, we do have photographers. We have a couple over at this table. Thank you so much. This is being recorded as well. So if you Unless you are standing up at the podium, you will not be on video camera, but you may be, have a picture taken. So if you would not like your picture to be taken, please just let the photographers at this table know, and they'll make sure not to take your photo. Emergency exits, if you walk out of this room, there is a whole row of emergency exits right there along the side, and there's lit up signs as well throughout the building. Pauline already mentioned what's in your bags. I'll just add that in your bags as well, there's an agenda for today and for tomorrow, so you'll know and be able to follow along with what's going on. So that is the end of our intro, and instead we're going to get right into things. To introduce our first presentation, I'm going to ask Barb Byers to come up. For those of you who don't know Barb, she is the Canadian Labour Congress Secretary-Treasurer, and she's a member of the CHC board. Our first presentation this morning is entitled, or this afternoon, is entitled "The Current Situation is Not Working," and it'll address the problems that we're currently experiencing in Canada, namely access to prescription drugs, unequal and varied coverage across the country, the high prices we pay, and the safety issues of drug company influence and doctors and prescribing practices.
Good, thanks. Thanks, Adrienne. And I'm pleased to stand before you this afternoon to introduce you to the first presenter who's going to kick this conference off. Dr. Steve Morgan is a professor of health policy at the University of British Columbia School of Population and Public Health. An expert in pharmaceutical policy, Dr. Morgan combines quantitative health services research with comparative policy analysis to help identify policies that achieve balance between three sometimes competing goals: providing equitable access to necessary care, managing health expenditures, and promoting valued innovation. I just slowed up because I just realized that we're doing translation, and yeah, and they like you to talk slower, so there you go. Dr. Morgan earned degrees in economics from the University of Western Ontario, Queen's University, and the University of British Columbia, and received postdoctoral training at McMaster University. He is the recipient of career awards from the Canadian Institute of Health Research and the Michael Smith Foundation for Health Research, an alumnus of Harkness Fellowships in Healthcare Policy, and a former LaBelle Lecturer in Health Services Research. Please welcome Dr. Steve Morgan. There you go.
So your switch is here, and it should be on here to go.
So thank you kindly for the invitation to speak here today. It's a true pleasure. This is a topic that I have been studying, as many of you know, for over 20 years now. And a number of you, Mike and others, will remember being at a meeting in 1998 in Saskatoon when we were talking about pharmacare for Canada with the federal government. And we thought we were ever so close to having reforms implemented at a national scale as they followed recommendations of the National Forum on Health in that era. We couldn't have been more wrong. 20 years on now, we're still waiting for those reforms. So this is a major file that requires a lot of hard work to encourage Canadians to be involved, engaged, to listen to the evidence, and importantly, to encourage politicians to listen to the evidence. And so I'm going to give a fairly long talk. I've got a full hour, although I'm not going to speak for a full hour. I'm going to go through slides fairly quickly, with apologies to the translators at the back, because I really want to talk about your role and the communities that you represent, the roles of those communities in taking us this next step, taking us these last few yards to cross the finish line, so to speak, on pharmacare reform. A lot of good has happened, particularly, I think, in the 4 years since the last conference hosted by these groups that are represented today. And I want to talk about what more remains to be done and encourage you to really roll up your sleeves over the next couple of days. So with that in mind, let me just get in, and I need to set my timer so I don't go too long on you. So here we go. I begin every talk reminding us that we actually, as a nation, have a fundamental obligation to ensure access to necessary prescription drugs for all Canadians. It's enshrined in this obligation is enshrined in a number of declarations of the World Health Organization that Canada is effectively a signatory to, that identify health as a fundamental human right, and access to health care by proxy as a fundamental obligation for governments to achieve. Universal, equitable access to essential and necessary services, including universal access to necessary prescription drugs. Consistent with that obligation, every developed country that has achieved universal health coverage has also achieved universal coverage of prescription drugs. Every such country except for Canada. This was not supposed to be the case. As all of you likely know, universal public pharmacare, like we know universal public Medicare to be in this country, has been recommended time and time again, dating all the way back actually to the 1940s, but most notably dating to major national commissions on the Canadian healthcare system, the Hall Commission of the 1960s, the National Forum on Health of the 1990s, the Romanow Commission of 2002. All of these commissions have made recommendations that Canada move forward on this long overdue stage of Medicare's development, and that is universal coverage of prescription drugs. The problem is that things get in the way of policy reform. And a colleague of mine, Catherine Booth from McMaster University, and I wrote a paper last fall about the politics of pharmacare in Canada. And Catherine Booth has written a book and several really excellent manuscripts on how difficult it had been to implement pharmacare in Canada in the 1970s, owing to a variety of issues that are maybe uniquely Canadian, our Constitution Act with its division of responsibilities, our federal-provincial tensions at various times in our history in the last 60 or 70 years. But there's also been some global things that have happened, like economic crises that made pharmacare maybe a little more difficult for Canada to implement in, say, the 1970s than might have ideally been the case. And then more recently, there have been a few new things that I think are really important in understanding the evolution or the lack of evolution on this policy file. We've seen that private insurance has filled gaps in coverage that existed in the 1960s, 70s, and 80s, and actually created an institution of a third-party payer through employment-based compensation schemes. That institution means that the median voter, the average Canadian, is probably lucky enough to have some kind of drug coverage. And in politics, that median voter is critical for reform. If you want government to take action on a policy file, it's the median voter that matters. It's that average Canadian who has to demand reform. And historically, it may have been difficult for us to see reform when the median voter was already getting private benefits through their employment. The existence of private insurance also created a stakeholder group, most notably the insurance companies, which in the late 1990s, as many of you know, were demutualized. They went from being shareholder-owned cooperatives to being investment-owned for-profit companies. That change in the late 1990s, as Michael Law has documented in a report in the CMAJ, was coincidental with significant increases in health insurance premiums and profits in the sector. That creates a powerful interest group that would like to maintain the status quo. So what is the status quo? Well, you all know these statistics. Canada has a fragmented system of financing medicines. About 35% of prescription drug purchases in Canada are filled by people who have some level of private insurance. 42% of prescription drug expenditures in Canada are financed by our public drug plans. drug plans that are typically targeted to vulnerable populations like the elderly, social assistance recipients, or people with significant health needs, typically specialized medicine needs or what we might call catastrophic needs in some jurisdictions. But a staggering 23% of prescription drug expenditures in Canada are out of pocket, which is a significant proportion of our total spend, but more than just its proportion is its impact on households. This is data from the 2015 Angus Reid survey of Canadians on their experiences with prescription drug affordability and accessibility. And about 10% of Canadians report that they have no prescription drug coverage whatsoever. Their household is entirely responsible for paying for the medicines that they purchase. Another 11% of Canadians report that they pay for the majority of their prescriptions they purchase because the insurance that they have, whether it's from government or through their workplace, involves significant deductibles or cost-sharing terms that mean, in essence, the household pays the majority of costs. That's a significant gap in coverage. We would not tolerate that for Medicare as we know it, as it relates to medical services and hospital care. And it's, interestingly enough, it's fairly significant in all jurisdictions. It's most significant in my home province, British Columbia, in part because our system of public drug benefits in BC is based on the premise that we will have public assistance only for people who have catastrophic drug expenditures, and those are expenditures that are a given percentage of household income. So I want to go through some of the literature on what we know about the system of drug benefits and what its effects are in terms of accessibility of medicines and the financial burden on households. And most importantly, and not most importantly, but given I am an economist, the thing that I can tell you most about is the burden on the economy, the burden on Canadian households, taxpayers, and employers in terms of the costs of medicines in Canada. Before I do that, I'm going to put things in an international context, but I want to talk about some facts and arguments about this, the system that we're talking about drug coverage and how it's situated within healthcare. So I want to start off with a couple of premises. First, prescription drugs are not ordinary goods, and this is certainly not an ordinary market. I think for a lot of us, we visit pharmacies and we fill prescriptions and we often pass over our credit cards and we receive something from a vendor that looks very much like an ordinary retailer. In fact, pharmacies in Canada are far different than the small, independent, professionally owned practices of pharmacy that you might find in many European countries. These are very big retail outlets that happen to sell medicines and may lull Canadians, and arguably Americans too, into believing that prescription drugs are just like other commodities and that they might need to be treated as such. But they're not. Prescription drugs are inextricably tied to the healthcare system, inextricably tied to how we would manage a health system to deliver on health goals for the country, to ensure that patients in need can get the care they deserve, and to use the system to promote the level and the equity in the health of the population as best we can, and ideally as efficiently as we can. The fact that it is tied so formally through prescription-only status to the medical system or the rest of the healthcare system also has a number of implications in terms of who gets to make decisions, and therefore who has some power in the decision-making process, and therefore who has some very significant influence both on the safety and quality of care provided to patients, but also, frankly, on the sales and profit margins of the manufacturers of medicines. Health professionals as agents on behalf of patients make them important agents on behalf of manufacturers of pharmaceutical products, or on behalf of the owners of the chain drugstores that operate in the Canadian context. So this is embodied in a system of uniquely tied to healthcare, but also in a complex system tied to various incentives and decision-making responsibilities, which at times can create conflicts of interest that result in decision-making that may not be ideal. Another reality that we are seeing more and more often in public debates around pharmaceuticals and pharmaceutical pricing is the reality that patients who need medicines are often vulnerable. Unlike purchasing an ordinary commodity, patients often don't have the luxury of waiting until the price goes down or waiting until a competitor comes to market at maybe a lower cost. The vulnerability of patients makes them keen to get access to treatments, and sometimes keen regardless of the price. And we are seeing globally a pharmaceutical industry now that is taking advantage of that, in particular for serious illnesses, people who are suffering from very dire circumstances if they don't have treatment, and people for whom there may be a limited number of treatments. And anyone who's worked in government trying to manage a public drug benefit program in this country or any other realizes that the price tag of medicines is going higher and higher every year, and at levels now that are well beyond any reasonable return to the health system in terms of reasonable measure of value for money, but also any reasonable measure of return on investment to the manufacturer's pharmaceutical R&D investments. Which raises one of the last things I think is really important here, is that the effects of medicines are very difficult to establish. As a consequence, manufacturers have to spend money on R&D efforts to bring a drug to market. They have to be approved by the regulatory bodies. But they also have to have data that shows the medicine works. Oftentimes, far too often, those data aren't made public. And even the data or the claims about the cost of the investment aren't made public, but more compelling or more problematically for the health system is the information about what is the true effect of a medicine on patients is often obscured in privacy and confidentiality clauses. I think we just lost our laptop. And that has serious implications in terms of managing a system of drug coverage in a way that is accountable and sustainable and evidence-based. And again, if any of you have ever managed a drug plan, as a few of you in the room have and do, I see you, and I've known you for years, this is a tough business, and it's an increasingly global phenomena or global challenge in terms of aiming for greater transparency of the science behind drugs that are being brought to market, particularly given the sometimes staggering price tags that they come with. I'm going to see if I can't advance this slide, but maybe we could advance the French slides and we'll test your bilingualism in the crowd. It's really test mine. The last thing I want to point out is that firms in this sector have extraordinary market power, not only because they are protected by patents, which is something that manufacturers have fought for successfully in trade negotiation after trade negotiation to enshrine a system of intellectual property rights for pharmaceutical manufacturers that is, frankly, quite generous, if we can use the term. But these firms enjoy a variety of forms of barrier to entry into the pharmaceutical industry that actually creates market power for the incumbents. And as a consequence, the industry is increasingly concentrated into a few large dominant players in the global marketplace, particularly within therapeutic categories. So defenders of the pharmaceutical industry will tell you there's literally thousands of drug companies in the world, and they're all relatively small and not very powerful in large number, or in the grander scheme of things. That's not entirely true. As you well know, the world's largest pharmaceutical company, Pfizer, did roughly $70 billion worth of sales last year, or had $70 billion worth of revenue in 2016. That's more GDP, more than the GDP of 5 Canadian provinces. Pfizer paid its top 5 executives last year $60 million. That's more than we invest in all of our national agencies to monitor the performance, quality, and assess the evidence concerning health systems, drug technologies, and regulatory policy in the pharmaceutical sector. That's just one company paying just 5 executives. So these are extraordinarily powerful firms. So this doesn't test your bilingualism. We're back on the English slides, which have no words. So where do we go from here? I've been working with colleagues internationally, and again, some of you are here, Ruth Lopert, who I've known for many years, and others, trying to think about how would you design a system of coverage based on evidence and based on principles of good system design for pharmaceuticals. The World Health Organization has helped us because they've repeatedly had publications out to talk about how to design a drug benefit. But a few things that pop out from this just as high-level notes. First, coverage matters. Coverage matters. If you want to fulfill this country's obligation to ensure that all Canadians have equitable access to necessary prescription drugs, there's no escaping the reality that all Canadians must have equitable and arguably complete coverage for necessary prescription drugs. Evidence around access to medicine show that even sometimes very small co-payments, even for somewhat well-off people, such as insured Americans who pay co-payments under their plan but have their drugs otherwise paid for, even co-payments for people who are lucky enough to have insurance turn out to be a deterrent to filling some types of prescriptions. And unfortunately for our health systems, oftentimes those prescriptions that they don't fill are the ones that keep them out of hospital, and therefore their lack of filling them is a driver of health system costs elsewhere in the system. So we know for sure that coverage matters, and systems that can achieve universality of coverage at low cost to patients will achieve better than others the fundamental obligation of universal access to necessary care. Talked a lot about the power of the industry and some of the difficulties in deciding what drugs work and what to pay for them. There is no question purchasing power matters in this marketplace. When single manufacturers have more funds available to them to manage the sales force and the promotion and the scientific enterprise that builds their case for covering a medicine at any price, you have to have some level of countervailing market power, perhaps by regulation, but perhaps by purchasing power, to keep the prices in check. Any system that relies on multiple payers when you have a single seller is an auction. Those systems favor the seller. And as a consequence, if you can consolidate purchasing power in a health system, you will achieve, in the long run, better pricing. Financial incentives also matter. And this, it's a kind of a logical outcome of looking at different systems that seem to be high-performing systems on pharmaceutical management and, importantly, on the acceptability of pharmaceutical management tools such as formularies, and, importantly, the powerful tool of saying no to a new medicine. If your system is designed with financing silos that seem to give the illusion that drug money is different than healthcare money, the population served by the system may be under the illusion, false as it may be, that it doesn't really matter what the price of a new drug is, it should be funded. But if your system is funded through a system that is reasonably integrated, where at the end of the day, the funding for medicines also comes from the pile or the revenue source that is funding for hospitals and funding for doctors. Those systems appear, at least on my reading of the evidence internationally, to have better stakeholder support for formulary management and sometimes tough negotiations with manufacturers. And as evidence is shown in a number of countries that have even gone all the way down to physician-level fund holding, those systems tend to encourage the use of older, tried and true medicines more than the use of new, maybe breakthrough, but often expensive drugs. And that might be appropriate in many cases for the management of patient needs, to use the stuff that we know is value for money and save the new stuff for the cases where we really think that that's the best available investment because we've exhausted other opportunities. So now I'll get on to the international comparison. I want to compare Canada to a number of countries internationally. I'm going to show you a very busy slide, and you're welcome to ask the organizers for it. I look at a number of countries. These are 10 countries that routinely take part in the Commonwealth Fund's International Health Policy Survey. So you say, well, why these 10 countries? Well, first of all, they're all relatively high income countries, above 45,000 Canadian dollars of GDP per capita. They're all countries that have achieved universal health insurance. The top countries here, New Zealand, the UK, Norway, Sweden, and Australia, are all countries that have more or less universal public health systems. Again, loosely speaking, we can talk about the nuances later. Canada has universal public health care as well. The bottom 4 countries, the Netherlands, France, Germany, and Switzerland, are social insurance systems. These are multi-payer systems in which you subscribe to a particular insurer. Oftentimes, if you're, for instance, living in Germany, you're based on your profession or your region. You subscribe to a particular sickness fund. In places like Switzerland and the Netherlands, you actually buy insurance from competing firms in those sectors that sell the insurance. But what I wanted to do is just point out how these systems look in terms of the design characteristics that I just put up. Do they have universal coverage? Is it low cost to patient as a coverage policy issue, or those 2 issues that are coverage policy? Do they have buying power in the sense that, do they have a single payer system, and or do they have something that is effectively a national formulary with effectively binding power of the ability to say no to coverage? And then lastly, are they reasonably integrated in the sense that does the financing for medicines ultimately at the end of the day come from the same system of financing that covers other forms of health care for the population served by it? I'm not going to belabor the point, and I'd love to have the debate over beers tonight with my pharmaceutical policy colleagues around the table of which country should be ranked in which color, but red is bad on this chart. Green is good, and yellow is subject to debate. Canada is all red. And the title of this talk is a prescription for failure. Canada's system, as we have it now, has none of the criteria that you would think, based on theory and evidence, would protect Canadians in terms of ensuring access, affordability of medicines, and equity of financing, and lastly, system level efficiency in terms of health system versus pharmaceutical investments. It's not looking good, and here's the data in terms of, well, how do we perform in terms of some of the key targets for pharmaceutical policymakers, the key benchmarks of performance in a system. And I've given talks like this now for more than 5 years. I've updated all the slides in the last couple of weeks, as the people organizing the conference know, in a bit of a panic. But we've got new data to show, unfortunately, that Canada is continuing to fall behind the pack. First of all, what about accessibility for patients? How accessible are medicines in Canada? The most important goal in this file, and we have for more than a decade documented over and over again. I think I've now published 6 papers on 6 different surveys that span more than 10 years showing that approximately 1 in 10 Canadians reports each year that they can't afford to fill the prescriptions that they've been written because of out-of-pocket costs. It is true that people in other countries report this, and there is variation, as you can see, in the other countries here. This is percentage of adult populations reporting this from 2016. This is fresh off the press. Canada is still at 10.2% of the population reporting these barriers. The universal public systems that we would compare ourselves have an average of, I think it's 3.6% rate of what we call non-adherence due to cost, or cost-related non-adherence. The social insurance systems have about 3.8%, comparable, because both of those systems of financing, whether it's the European ones or the former mostly Commonwealth countries with public systems, they have reasonably good coverage, universal coverage at relatively low cost to patients. Australia, not particularly the best amongst the universal public systems because they have high co-payments. And Switzerland, not particularly the best amongst the social insurance systems because part of the thing you do when you buy social insurance in Switzerland is you choose your deductible. Deductibles have proven time and time again to get in the way of patients filling prescriptions. But let me get to the punchline. That difference between us and the comparators translates into 1.8 million adults are not filling their prescriptions more than we would see if we had the systems or the average level of access in other countries. So put it another way, if we could bring ourselves down to either of those comparator groups, 1.4 million Canadians would not be reporting this problem. essentially, if we had universal pharmacare, there'd be 1.8 million Canadians filling prescriptions that they currently report they can't. So let's look at just the roughly 1 million of those people who report that they routinely use medicines. So, you know, maybe 800,000 of those people are just not filling a prescription for a painkiller that they just periodically needed because of tennis elbow or what have you, but they get it over the counter, and that's what happened, and that's what was being reported. But for the million people who routinely fill prescriptions and are reporting this, US survey data suggests that at a minimum, 2% of those people, I know it doesn't sound like a big number, but 2% of those people will experience a significant deterioration in health as a consequence of their inability to access medicines. And that's an attributable fraction based on calculations from one of the national medical surveys of the United States. So in the Canadian context, that means that approximately 20,000 Canadians every year are experiencing some significant morbidity, some significant deterioration in their health because they can't fill prescriptions that they would be able to fill if we had universal pharmacare. And I'm not saying bringing 10.2 down to 0. I'm just saying bring us down to the rest of the pack that have reasonable performance. Coverage matters. There was a study published in 2012 which not enough attention has been given to by a group of folks in Toronto associated with ISIS, who showed that amongst diabetics in Ontario, the income-related difference in morbidity and mortality amongst Ontario residents with diabetes was far greater for people under the age of 65 than it was for people over the age of 65. What happens in Ontario on your 65th birthday as it relates to prescription drug coverage? You become eligible for public benefits, which, to the credit of Ontario, are roughly comparable to the kinds of benefits that people of all ages would get in all of the comparable countries we look at. But the group that did this study in Ontario, led by Gillian Booth and others in Toronto, were able to calculate how many fewer deaths amongst residents of Ontario with diabetes would occur if the level of income-related inequity amongst non-seniors with diabetes was similar to the income-related inequity amongst seniors. It's complex, but it just basically says they're not going to eliminate income-related inequity. But what if you brought it closer to the level that we see for the population that gets complete drug coverage? They calculated that more than 800 deaths per year amongst working-age Ontarians with diabetes would be prevented. Now, the attributable fraction strictly to drug coverage can't easily be computed. I would estimate that maybe a quarter of those deaths truly are strictly because of drug coverage, based on other studies that have tried to do similar attributable fraction estimates. That's a wordy way of saying it's not 800 deaths probably strictly because of the gaps in pharmacare in Ontario, but it's probably 400 in Ontario, 200, sorry, in Ontario every year. And if you multiply on that result for Ontario to all of Canada, and even if you assume that there's no benefit for Quebec because they've already achieved some level of universality, that's 400 residents per year who pass away prematurely from diabetes alone in Canada because of their difficulty accessing medicines while of working age. And what's interesting is that that's premised on the assumption that the coverage that we have for seniors is a benchmark. And it's important also to note that although non-seniors in Canada actually have worse coverage than seniors do, both seniors and non-seniors do worse than their age-matched comparators in all of those comparable countries. We just did a study a couple of months ago in BMJ Open, which showed that Canadian seniors have 3 times as high a rate of cost-related non-adherence, that financial barriers to prescriptions, as seniors in comparable countries. Canadian non-seniors have 5 times the rate. So to sum those ideas up, reasonable estimates on the low side would suggest that every single year, our lack of universal pharmacare, a universal plan that may be equivalent to the Ontario Seniors Drug Plan, results in something on the order of more than 20,000 negative health events, 20,000 avoidable negative health events, many of which would require hospitalization, and more than 400 deaths every year. We should, although I have time enough that I don't have to, but we should stop there. I mean, there should be rioting in the streets. Avoidable mortality because we don't do something that every comparable health system in the world does. 20,000 people suffering every year, and 400 people or more dying every year. That is like a plane crashing to the ground, a plane full of Canadians crashing to the ground at least once a year, and government officials are standing by, elected officials are standing by, hemming and hawing about whether we should fix the problem. It's egregious, and what makes it even more egregious is the fact that we would save money if we fix that problem. Not only would we save money in our healthcare system because people would not need to use the system, particularly the hospital system, as much if we could keep them healthier and out of hospital, but also because of that purchasing power story we talked about. This is per capita expenditure on medicines from the OECD amongst the comparable countries. It's hard to tell the coloring here, but the lighter blue colors are the multi-payer systems of Europe. The darker blue colors are the universal public systems. And again, if you can ask the organizers for access to this slide, I'd be happy to show it. Canada is well above international comparators. More recent data suggests that Canada is now creeping up again. We plateaued a bit for a couple of years. But I want to draw this line here and just have a look at our per capita spending level. The insurance industry and, unfortunately, a number of government officials want us to embrace a multi-payer private-public solution to pharmacare in Canada. They want us to look like those light blue lines in the system, in this chart, which don't do particularly well on expenditure control. The Dutch system does, and we could talk about that and have a debate again, maybe over pints this evening. But on average, the Dutch system is, the multi-payer social insurance systems are much more expensive than the single-payer public systems internationally. If we had the level of spending that they have in those social insurance systems, we would save $4 billion a year. $4 billion a year is real money, for sure. It's a significant savings to the system. If that sort of multi-payer system could be run with a single national formulary with binding yes or no decision-making power. I don't think the insurance companies want that, because that removes the ostensible choice that makes them valuable to people who are insured by them. But nevertheless, if you had that, we would save $4 billion a year. But if you look at those universal public systems that have single-payer purchasing power, that really do have the power of yes means yes and no means no, the level of difference between the average, that green line for those public systems, in our system translates to $12 billion per year. To put that number into perspective, $12 billion a year is enough money that you could double the number of family doctors working in Canada. It's real money. You could fund a universal child care program with $12 billion. You could do a lot of good. You could fully implement a national strategy on mental health in Canada with $12 billion. Actually implementing the recommendations of the Mental Health Commission of Canada for $12 billion. So $4 billion to $12 billion seems to be the rough kind of range of estimates by which we could save, or estimates of how much we would save as a country. In a few weeks, we will show, once again, with yet another paper, just how Canadians are being screwed on pricing of medicines and prescription insurance in this country. We've got an analysis comparing Canada to those other countries I just showed you. And we don't spend more money on medicines in Canada because we use more medicines. We do use about 3% more than our comparable countries do, which is fascinating given we also have high rates of cost-related non-adherence in Canada. But the biggest difference is that we purchase medicines or our doctors prescribe medicines that are on average 20% more expensive than the cost per day of therapy from similar therapeutic categories that patients would receive in those other countries. That's the effect of financial incentives, I believe. Doctors being more likely to prescribe older, tried and true drugs because they know that at the end of the day, if they prescribe an expensive drug when it's not necessary, the extra money comes out of their health system. It could even come out of their paycheck. But it is the prices. In fact, there's a famous essay by American scholars about why the US spends so much money on medicines, and the title of that essay is, "It's the Prices, Stupid." And it is the prices, stupid. We pay stupid prices in Canada for medicines. And it's partly because we have this fragmented system of purchasing with private insurers in this country who boast in various fora that they more or less don't say no. They'll cover anything. They'll give you choice. They'll give your doctor choice. The problem with that is that it eliminates any negotiating power. And again, any of you who have managed drug budgets or any of you who have bought a car from a dealership know that if you go onto the lot, say, I have to have a car by the time that, by noon today, you will pay the highest price that that dealer has ever charged for a car. And in some sense, private insurers in Canada are probably, amongst institutional payers in the world, paying the highest prices for medicines of any institutional payer in the world. So we have a failing system. We pay way too much money for a system that's resulting in access barriers that unquestionably are causing harm to Canadians. We don't have precise estimates of the harms, but we sure have precise estimates of the costs, and we sure have evidence accumulating from a number of studies that there really are harms. How many? Is it 400 deaths or 800 deaths? We don't know. So I want to talk a little bit about moving forward, and I think that there's a danger that we could be moving in the wrong direction. There's been a lot of talk about pharmacare in recent years, and we're at a time, again, that looks a bit like the mid-1990s or the late 1990s, around the National Forum on Health, where there was energy and enthusiasm, something might actually happen. But what would be troubling is if we went in the wrong direction. I'm going to skip one slide, and never mind that one. I want to ask the question, and we're going to talk about this later, is the Quebec system of mandatory insurance the right way to go? This slide shows the public spending, that is taxpayer finance spending on medicines in Quebec before and after the implementation of their compulsory insurance system. This system was brought in by a government that specifically wanted the new system to reduce taxpayer spending on medicines. It did not do that. Taxpayers are on the hook in Quebec almost exactly the same amount as they are in the rest of Canada. This is the reason unions, employers, and households should be livid about a proposal for a Quebec solution in Canada. Before Quebec implemented its universal mandatory insurance system, households and employers financed about the same amount per capita for medicines in Quebec as they did in other provinces. Since that policy change, and this data goes all the way back in the 70s too, it's almost identical to the 70s. But since that policy change, the difference between Quebec and the rest of Canada has grown to more than $200 per person in the province. Not per insured person through the private sector, that's per person province-wide. If Canada adopted that system, we would be spending more than $7 billion a year more on medicines. And we already spend somewhere between $4 billion and $12 billion more than any comparable country. We shouldn't go there. And I'm getting the stop sign, so I will stop in another 2 minutes. Should we go BC's path? We're going to hear about this too. These data, published just 2 weeks ago, show, again, kind of update an analysis of the concentration of drug costs amongst people who need them in British Columbia over time. This is where you rank on one side, up and down, is the population of British Columbia based on how much people spent on prescriptions in 2007. And we followed those people forward to 2011. I only want you to look at one box, the 72% bottom corner here. The 10% of the population that had the highest level of drug expenditures in 2007 those people had a 72% chance of still being in the 10% using the most amount of prescriptions in 2011. For those people, the deductibles under British Columbia's income-based drug benefit system, 3% of household income is a tax on the fact that they have chronic illness. It's staggering. And so we really need to think about the fundamental justice and equity of financing issues when we think about systems of financing like that. It is a burden on the elderly and a burden on the sick. So when will Canada do this? When will we do the right thing? Well, the question is, will we do the right thing? And I think there's a variety of reasons to believe that the federal government right now, frankly, does not want to do the right thing and may actually prefer doing something that enshrines a quote-unquote role for the private insurance industry. But all the evidence internationally suggests that that means enshrining a system that will be unfair, because it will be distributionally inequitable, and it will be inefficient. It will cost us more money in the long run. I'm really glad, I just want to get to my closing point here, that we really need to push. Academics like myself and others need to continue to do science, and we need to write papers and write papers and write papers and answer questions that are still lingering in the minds of policymakers. But the public need to be engaged. The only way, to be clear, that the federal government is going to overcome the power of these incredible industries, incredibly powerful industries that benefit from Canada's status quo, is if the public, the median voter, forces them to do this. This e-petition, 959 I think it is, which there is a flyer on each of your tables, that's something, one place to start. It's the public stepping up and giving a signal to government just how important this is. But I think it's really important for labor and business to work together, to have a coordinated call for reform. It is important not just for seniors to get engaged, although I think it's great that they are, but we need the millennials to get engaged. The federal government, as many people have argued, is governing to the millennial generation. This is a generation that will grow up in a workforce without private insurance for medicines. They need to be involved. You need, if I could ask you to, find a way to reach out and engage these communities and that generation, because it's critically important. Anyhow, with that, I'll end. I'm sorry for painting a dismal picture, but I think this meeting is important because we need to mobilize, Canadians need to speak up so that governments will have the courage to do the right thing. Thank you.
So we have time for questions. Don't worry, you know, there's lots of Eeyores in the room here. It's really bad and it's going to get worse. But this is the group that's going to change that, okay? So questions for Steve, and just before the e-petition, we will have a computer available at the back of the room. Okay, on the Canadian Health Coalition information that's in the hallway there for you to sign the e-petition either today or tomorrow. We'll make it easy for you. And honestly, I did it myself, and it's really slick. It's very easy, and 3 to 4 minutes and you're done. It's not a big, long, lengthy process.
And if I could say, there's only a few thousand signatures on this, a couple of thousand, I think, right now. There have been a couple of people in Nova Scotia who have really took this up and actually started campaigning, you know, just doing emails and really bugging their friends and neighbors and their professional peers, academics as it is. We need that kind of effort in all communities to sign this kind of thing. It's not going to make policy, but it gives government confidence. If 10,000 Canadians signed this petition, government would have more confidence that they were heading in the right direction by doing a pharmacare program.
So we have a couple of microphones on the floor. Go ahead, mic number 2.
Hi, Denise Bernardo, and I'm from British Columbia, and so I'm dealing with benefits and drug costs, and I'm also a pharmacy tech, sorry, I should actually say that. I'm dealing with drug costs both at a pension plan level and as a trust, a new joint benefit trust in BC, and so this is really dear and to my heart. One of the questions I have, though, is you mentioned about in BC, like the pharmacare, and I always had Maybe if you could explain that a bit further, because I know, if it's income-based testing, but at least to me, that means that people that can't afford it will get it. So I didn't quite understand your point about how it was an additional tax to the people that were actually using it.
Yeah, so the way the BC system, and we'll hear about BC later today, the way it works is that the deductibles for every household with income above $30,000, which is fortunately the vast majority of households, every household with income above $30,000 pays the first 3% of their household income towards their deductible. That is, that they pay out of pocket or through private insurance if they're lucky enough to have it, until their drug costs hit 3% of household income. Then the public subsidy kicks in. There's pretty good evidence, both when the policy was implemented, but also more recently. Again, we published a paper a few weeks ago in CMAJ Open that shows that actually the deductible structure in BC seems to have an impact on patients' access to medicines. And most importantly, the focus of our work recently was on cardiovascular treatments that are preventative. And I did a number of other pieces as tests, and it looks like the patients will forego the medicines that you most want them to fill, the ones that keep them out of hospital.
Mike 2 again, please.
Thank you. Peter Bergmanis from the London Health Coalition. I am very curious, though, where your thoughts would be as we run headlong into governments of both conservative and the liberal stripes are really free traders and worship that free market economy. And they sign off on trade agreements that are very secretive. And we all know that CETA was part of this kind of regime where patents would be extended for perpetuity for drug manufacturers. And we know that NAFTA has also codicils there that would probably make it almost impossible to introduce a universal public pharmacare plan. So our politicians talk out of both sides of their mouth, but they don't seem to understand that once the public door is closed, you can't get back things that are already elements of private, which we have all too much of. So how would you play this?
Yeah, so I don't want to overplay the trade agreement issues, because this is geopolitical stuff where Canada is engaged in trade negotiations. We should fight to make sure that our representatives get a deal that is right for us. Ruth Lopert is here. She's written a number of important pieces on CETA and other issues, and she was Australia's, one of the main negotiators when Australia sat down with the Americans to negotiate trade, and one of the things that she did was protect their system of universal public coverage for Australia during those negotiations. What I will say, and so you should talk to Ruth, what I will say is that increasing the power of manufacturers in this sector makes the case for universal public pharmacare greater, not worse. It makes the case for having the purchasing power of a single accountable public monopsony, single buyer, stronger. And if we continue to have fragmented purchasing power with increasing power for the manufacturers, Canadians will still find that they are getting fleeced, essentially, with the highest prices in the world. So trade negotiations, we need to argue for the best possible deal for Canadians and for our partners abroad. Let's have the deals work for citizens in all countries. But as it relates to pharmacare, I would not want anyone to think that this is a case against pharmacare. If anything, if you're going to do trade deals, you need to have pharmacare to protect you.
Mike 2 again, please.
Hi. My name is Edward Napke, Dr. Ed Napke. I'm certain that I'm the oldest guy here. I'm in my 94th year.
Wow.
And I do believe at birth, every child in Canada should have easy rights to having proper medication. Having said that, medications are poisons. They have to be in the right hands, and the people who deliver it make out the prescription, because I notice you're talking about just prescription drugs. There are other means as well. We do not have a good system of teaching our doctors how to prescribe and what the limits are. In fact, too many people are overprescribed in Canada. We have underprescribed and overprescribed. But this is not candy you're prescribing for. These can kill you. And we need a system of monitoring that puts an implication on the companies. Are you really have an effective drug? Are you using statistics like you have all through this? Would lie quite often, or it depends on, because you make a good salesman for the drug companies. Get more drugs on the market. That doesn't, not the same as get better drugs on the market and get people who deals with this better trained. It's too easy to prescribe. I've created the Canadian Drug Adverse Reaction Reporting Program since 1963. I'm still involved. Involved with the Canadian Poison Control Program. Still involved. I'm a consultant to World Health Organization Uppsala Monitoring System. And the system has not changed in any way. In fact, it's bad. The legislation, the regulations deal with, they call it a drug. I said, what is a drug? It's not, as per definition, it's not an active ingredient. The patient gets a drug product, and that's loaded with stuff. You cannot go from one drug product to another without data behind it, and we don't have regulations for it. 1987, the House of Commons unanimously voted for all the ingredients in a drug product to be listed so the patient can act as a warning system. What other things are in this? And some drug products have between 2 and 40 chemicals generally regarded as safe, but they're not. There are exceptions to it. So I feel getting more drugs on in ignorance isn't the game to go at. We have to get people who know how to handle this drug product effectively and for the right populations. Longevity in Canada is better than most countries, in spite of all what we're doing here. And it's not a matter of dollars and cents.
Thank you. I think just to say that pharmacare is, the system of coverage and reimbursement is one pillar of a true national pharmaceutical strategy. Marc-André Gagnon, Joel Lection, Barbara Menzies, and I, and Jamie, I can never remember who I wrote which papers with. We have a paper on a national pharmaceutical strategy where coverage and policy is a pillar, but safety and effectiveness and evaluation is another pillar, and quality use of medicines and public and professional education is another pillar. So we need the full strategy to make sure that people can afford medicines when they are the right treatment, but also that we are using these treatments appropriately, and that not just the prescribers and health professionals are prescribing them appropriately, but that patients understand the questions to ask and understand where and when medicines are appropriate and where and when non-medicinal treatments might be the right thing. So we need, I think we need a suite of policies. Luckily, the cheapest of the policies that you could pitch to the federal government right now is a true national strategy on appropriate use of medicines, which I've pegged at $50 million a year, which by comparison to my $5 billion a year ask of the federal government for pharmacare, $50 million seems viable. And if I was to place any bets, that's the one that they might pick is a 2017 sort of policy promise on Canada's 150th anniversary, but we'll see.
Mic 2 again. People are afraid of mic 1, are they? Mic 2, go ahead.
Hi, my name is Carol Reese. I'm with the Canadian Arthritis Patient Alliance. I'm a patient advocate. So my biggest concern is having ankylosing spondylitis. And, I understand, it seems a little bit simplistic, but yes, it's important to, save money and cost savings and and that, but, you know, having a condition that's chronic, that there is no cure, and having to cycle through several biologics that are quite expensive. For example, it cost me about $5,000 just for one medication a month. And this is my third one in the span of 4 years. And I've failed this last one and having to start a new line of a biologic. So with this, you know, new, you know, idea of, you know, a healthcare system, and it seems simplistic with a condition that I have. You know, it's like, where does someone like us fit in all this, where, you know, we need choices, and, you know, we don't want to go for the most expensive. We don't want to go for the newest, latest drug, but sometimes we have to. And we don't want to take these medications. You know, there's a lot of risk involved taking these, and we don't take them lightly. So it's, you know, how does one, where will we fit in this, for example?
Well, thanks. I think it's a really important question. And if the system was designed appropriately, you would fit in just like everyone else, that your legitimate medical needs would be covered. And they're not right now under our system. And I think that the stakeholder groups tend to try to use fear tactics of, you might fall through the cracks of this newfangled idea of pharmacare. Although the idea is as old as the 1940s and has been in place in most comparable countries for many decades, you know, it is a system that would benefit patients with common conditions, and if done right, it should benefit patients with rare diseases or complex needs. I think it's fair to say, and I haven't done an assessment of the formulary coverage, say, for arthritis or other inflammatory diseases in the 8 or 9 comparable countries that we had up on these charts. But I would be willing to venture, and I know I can see around the room a few people who would know the answers for some of these countries, I'd be willing to venture that coverage is better for the average patient with arthritis in all of those comparable countries, even though those countries spend less in total on medicines. One of the advantages of saving money on garden variety treatments that, you know, are cheap and cheerful if you can get them in generic, is that you free up resources for the more expensive specialized treatments. And so it's, what I'm saying may sound at times simple, it may sound at times glib, but, you know, it's within a complex structure that if it's designed well, and there's a number of good examples internationally, which we'll hear about, I think we can, in fact, have choice, appropriate choice, therapeutically appropriate choice, and savings and access.
We'll take the 3 people who are waiting to ask the questions, and then we'll go to break. So we have Mike 2, then Mike 1.
Jim Calvin, a member of the Hospital Employees Union, CUPE's Healthcare Division in BC, and I'm a care aide. And I've got 2 questions in regards to research. One, when we did the lobby back in January, 2 out of the 3 parties were relying on an argument that Big Pharma was driving fear about the stifling of profits that would be used for research if it went to a national pharmacare program. And we weren't buying it, but where there's smoke, there's fire, and that means that there's a lobby going on behind the scenes. And we had responded to the 2 parties that 2/3 of the world that has national pharmacare plans don't have this issue, so obviously it's a moot point, but I haven't seen any research. That doesn't mean it doesn't exist. So question number 1, is there any research that would stifle that argument in advance of Big Pharma? And question number 2, I see your stats and the information. I'm from British Columbia as well, so I see it about the catastrophic cost of death. But you come through our hospitals, and something that doesn't get as much attention, but is going to, I think, is even more costly than the deaths, unfortunately, is all the beds that are jammed from people who can't afford their medication. They're the ones that, once they get it, are able to return back to as normal a life as they can. But the costs of coming back into emerge to be admitted to get their pharmaceuticals for free is very real. It's happening in every emergency department across Canada, and those aren't being factored in. I think that $12 billion is going to be a lot higher once they factor in that. So the question about that is, I know BC had released some through the health authorities, but I don't know if it ever got picked up by researchers or carried on more on it. So those are my two questions.
Yeah, thank you. And two really important points. On the issue around the health system implications of getting people the treatments they need when they need it, Dr. Nav Prasad, who's here, is running a trial in Toronto around at least getting patients on an essential medicines list and seeing how that benefits them in terms of adherence to medicines, and ideally, if the sample size can get big enough and we can calculate some outcomes to the system. There are a couple of studies in the United States that give us a business case in terms of hospital offsets from improved access to preventative therapies. So, asthma, diabetes, heart disease, there's a number of therapeutic categories where it's kind of, the manufacturers tout this all the time. It's unequivocal. If you get patients the medicines that they need when they need it, they tend to stay out of hospitals, at least more often than if they didn't fill their prescriptions. So there is a business case there. There's some writing in Canada about it. As it relates to the R&D story, industry holds that up, and it's tough for an MP or an MLA because they'll talk about job losses in your riding, and we're going to shut down grants to your universities, and we're going to do this. It's nasty stuff that happens. It's always a lie. We've written about this. I think I wrote about this maybe 5 or 6 years ago in the journal Healthcare Policy, when British Columbia was confronting such a lobby about how evidence-based coverage policy in British Columbia concerning its formulary was harming the R&D climate for BC, and we showed without a doubt that wasn't true. We also can point to international evidence. Of those countries that we're looking at in this chart, most of those countries spend significantly less than we do on medicines, and they attract significantly more R&D. The UK is a good example. They spend 40% less on pharmaceuticals than Canada does. They attract 5 times as much R&D on a per capita basis. So, it's a bargaining game or a political game that the industry plays. Maybe one of us can write a paper again and get it out into the newspapers and get it out there for people to see, but the data don't support the claims at all.
And Mike 2.
Good afternoon. My name is Trish McAuliffe. I've come from the Durham Health Coalition. I'm the co-chair. We've been working with Natalie Mera for quite some time on some local campaigns. There was a great amount of us that came in February and did a local our local community MP lobbies. And one of the MPs, in fact, was our neighboring MP, Dr. Colin Carey, who actually refused to meet with us when the Conservatives were in power on a very similar issue. The Canadian Health Coalition spent a great amount of time to organize us to be there. He refused to meet with us, and he was, just prior to that, he was the assistant to the Minister of Health. So now in our community, when we go to visit him this February, he's all open doors. Oh, yes, this is a great plan, and this should be, it's all welcome, and this is very informative, and we need to get the Liberals to take notice to this. So really, it's about political will. And in the three other lobbies that I did that day, I really come to understand the MPs have no clue. You know, there's a real fallacy amongst us as we're citizens in our community. You think, oh, it's so daunting to knock on the MP's door and say, you know, this is what I want to talk about. And you think that they know everything. They know nothing, right? So the one thing that we've been able to bring home was the fact, when we were able to speak with MPs, that they are really in the dark about the misleading information that's out there, whether it's the lobbies that are visiting them prior to us or after us. We know they're there, but the power of the people is that matters. So we're back here again, this time as members of our community, to get more information, great documents that you've provided for us, to go out there again and give this information. Most importantly, to those precarious workers in our community. That is the #1 group that we need to get. I'm with the retirees of Local 222, and I sit on so many other boards in our community, and seniors, you know, have access, but we have to find a way in which we get to the informative years of those people ready to graduate out of university with no, you know, they have no coverage. My sons are 22 and 23, and we have to find a way to get them to attend with us to the MPs and really make it happen there. So if there's any way we can do this, it's maybe outside of our unions. Those precarious workers need unions, number one, but we need to find a way to get to them. So thank you for all you do, and thank you. Please keep sending us the information. It's great. Thank you for all the work you do.
Thank you. Thanks, and I'll just say, I mean, as academics and researchers in this field, we're pretty good at producing research. We're terrible at communicating it, and so we need those that are in the communities, those that are with public interest groups and unions. We need employers. We need after this meeting, I hope this next couple of days is a momentum building exercise. Rather than patting ourselves or yourselves on the back over the successes since your 2013 event, which you should do, but you should do that and double down and find a way to coordinate, communicate, and develop the public education campaigns that are necessary. And I'm glad you see the value in this millennial thing. We need millennials for pharmacare. We need that to start up.
And the final word, Mike 1, Barb Byers.
Yes, Barb Byers, the Canadian Labour Congress. So actually, this is a good segue into what I wanted to say. First of all, I want to reinforce the need for the universal comprehensive idea of pharmacare, prescription drug coverage, whatever you may call it. Just on the basis of what we've seen with Medicare, the more they've hollowed out of the system, from taking it away from not just publicly funded but publicly delivered, we see then the support starts to go away. So I really support the comprehensiveness, because I think to be very limited will be a very limited group of people, and it will never expand past there. So that's sort of where I stand on this. The second thing is really about what our responsibility is, because one of the things I've learned as they got me back onto tweeting is I cannot tweet and concentrate at the same time on what somebody's saying. So what we need to figure out, though, is those gems that you've already given us and that other people are going to give us, and how to get those out to people in manageable amounts. I think we need the extensive research that's written in accessible ways, which you've done, but we also need to give it to people in sort of portions that is accessible. So that's number one in that, and that's up for us to do as well. And in terms of the question of what do we do, when I was listening to you speak near the end, and also people that have come up, I kept thinking of, well, two things. One is people who've gone before us. So Shirley Douglas, who would often talk about how horrible and dangerous, actually, the fight for Medicare in Saskatchewan had been. Many of us think that it was had happened and everybody embraced it. It didn't. And so we should be prepared for some of that. The second thing is I was thinking of Monique Bégin, who I'd heard a number of years ago that talked about, as they were coming to bringing in the Canada Health Act, she went in to meet with the Prime Minister, who said, okay, so we've got to make a decision on this. I mean, I'm not going to get her eloquent words right, but she was questioned about, okay, so who's on the side of the Canada Health Act or Medicare at the federal level? And she said, well, Mr. Prime Minister, all the premiers are against it, and all the finance ministers are against it, and the federal cabinet is against it. And he said, well, so who's for it? And she said, the people are for it. To which the response was, well, then I think we've got a winner. And so what I think we need to do is take those words, and hopefully I've got them reasonably close to how Madame Bégin presented them, but I've kept that in my mind for a lot, is that if we actually build this up, we can actually, it can become a reality, but ours is the responsibility after we leave here.
Yeah, thank you. And I think you're dead right that this isn't going to happen unless it becomes a household conversation and people are well educated. That's not going to be researcher driven. It's going to be driven by people who can hire the professional communicators who can put things into the sound bites and to tell the stories. So, you know, Bill Swan at the table over here is creating a Faces of Pharmacare, is that what it's called? Website, which, you know, the kernel of the idea is about stories and how people share stories on social media and when they're telling people this lovely story about Monique Bégin and others. Those are things that we, you know, communications professionals and a true communication strategy would do. And again, coming out of this, I think maybe it's about how do people work together. The academics, I think we'd be more than happy to do all the research and fact checking and, you know, checking things over. But we can't do the communication stuff, and we certainly can't tell the stories in a way that's compelling. But if you ask Monique Bégin to get in front of a camera for a half an hour with a professional communicator to get that story about how, if that's a true story, you know, about Pierre Trudeau, I mean, it's a lovely narrative about standing up in the face of opposition on behalf of the public, and that would, I think Canadians would share that story.
And if I can just comment on that, the storytelling is something that we don't do as well as we could.
Yeah.
And I know that from years in the labor movement, people will say, have you got somebody that can speak about this or that from a personal point of view? And we don't do that, and we've seen it used against us. And if I can use the words of Dr. Day in this room, I mean, they've figured this out. They're telling stories, and that's what they're hoping is going to move people.
Yeah, absolutely.
So once again, thank you to Steve and to all of you. The questions were great, and we have a small gift for you, because we know people like presents. And thank you. So we'll have a health break now for 15 minutes. And so synchronize your watches. Okay, can you be back at 3 sharp?